And we're live.
All right, good morning. This is Senate Health and Welfare. It is March 11th and on March 11th in 2020, just a little
Birthday week.
factoid for us. Did you hear it this morning on Vermont Public? But on March 11th in 2020, we were told to shelter in place. And on March 13th, 2020, the Senate and the House, or at least this committee, was operating by telephone. And that was, talk about a disaster, but that was difficult. It was very difficult. And then very, very soon after that, we started functioning on Zoom.
Within 10 days.
Within 10 days, we
Legislature was already
converted
functioning.
in person to telephone to Zoom, passing all of our resolutions that were needed in order to do that. Became an electronic legislature. Government was really amazing. And it was, someday we'll have to sit down and write a book collectively, because that was an experience and a half. And then working through, I remember sitting at my computer. I know the rest of you will remember too, but sitting at my computer, and I typed up 13 pages of proposals of things we had to do in order to meet the public health crisis, whether it was in economic development or other. I don't know where those 13 pages are now, but they did something good. And then we went on from there, and we met all summer, and then we came back and we met again. And I think we might have met a lot of the summer of the following year. I don't remember
I was chairing joint fiscal.
Oh, you
that
were very
year, and all of the federal money was a grant, and so joint fiscal had to approve them,
right.
and we couldn't appropriate anything. So there was a lot of negotiation with the administration as to how money would get spent. So my memory is I didn't go home that year.
No, it was like a perpetual motion. And it was wherever you were still in the Senate.
Yes.
Or on your committees. And so, I think people don't understand that, how hard it was to do that. I know that other people had challenges outside of the legislature and government who were trying to make ends meet with their jobs and getting in food lines. And it was difficult.
It was hard to teach.
Yes, and you were teaching. Oh my
It was
gosh.
very difficult.
So
It'd be interesting to study that, because Montreal didn't close schools.
really,
And so, but they are much like, if your town was in a red zone, you couldn't go to some place that was in a yellow zone.
oh,
They were really strict.
oh, they had
Like
zoning.
$2,000 fines and roadblocks.
Yeah,
Wow,
we were seen
wow.
outside on a park bench.
Would be interesting to hear about that.
Yeah.
So we need someone who is in the film and industry to do a little documentary on all the things that happened in the
I
Western,
was just thinking.
Eastern and Western hemispheres, from the Northern and Southern hemispheres. Yeah.
Cool.
Well, okay, what we are now on an agenda in front of us, we're going to be talking a lot about our healthcare payment and delivery system reform bill that we have.
Yeah, but that's it. Oh, thank you very much.
There you go.
Yes.
And before we did that, I thought I'd just walk through some of the bills that we have in committee and what our week looks like. The goal is to complete work on the committee bill by listening to folks who have been engaged with this, including AHS. And so I wrote down some things to think about as we go through the committee bill. I know I read off the goals last time, and I will read those goals off again after we've had some more testimony. But the Agency of Human Services do they need consultants? How are they working with community groups? What is the relationship with Blueprint that we're looking at in this bill? And then, of course, there's a head that we don't touch in the bill, but certainly we're going to want to just talk with them a little bit about. Green Mountain Care Board, What, if anything, is the board able to access through the ACO and for quality metrics and helping with clinical evaluation? And then their analytics and their evaluation, budget oversight, reference-based pricing, which is huge for hospitals, and how we begin to control the escalating costs that are putting all of us in dire straits in terms of insurance premium, commercial insurance premiums, and others. And then we are going to hear from the hospitals about the issues that, and we're going to hear from them today. I don't want to go into what they're going to be talking about, but certainly we have some things in there that relate to hospitals very strongly. Not the least of which is reference-based pricing, global budgets, and then the finance piece and how the hospitals coordinate finances to be more uniform. And then we have Vermont Medical Society. We'd like to hear from them and a particular effect on our primary care folks and on Blueprint. We'll hear from Vital because they have some comments to make on the section related to EMR, electronic medical records. And then the healthcare advocate will want to comment on his involvement and where he sees that work going on. So those are some of the things as I was walking through, there's a lot in the bill, not to ignore the state plan that we're looking for, but I know there'll be a lot of discussion about that and how quickly that can happen and what it means to have a plan in place and who does it affect when, where, and how. So there's a lot. So we also have in the committee that I know you've heard from constituents regarding ophthalmology and optometry and the expansion of scope of practice for optometrists, S64. We have that bill from GovOps. I know there's a lot of interest in the bill. It isn't a simple bill for us in this room. We will go through it and have an understanding of what's there. The GovOps has taken a lot of testimony, mostly from optometry, but we're going to have to get some testimony in here and balance it out and sort out. I am not optimistic that we're going to be able to go through that bill by crossover with all the other things that we're looking at. We're also looking at the dual bill.
Friday.
Yeah, crossover is Friday. I'm looking at the dual bill S53. We'll hear from OPR about that, I think, tomorrow. We are looking at S36, the bill that we started working on with recovery programs, recovery residents, integration of a system for recovery for folks on substance use disorder and including co-occurring disorders. We also have another bill called S63 on Green Mountain Care Board has recommended for some of their work. We may be able to get that one out, or at least most of it out. And then we have been given, which is a good thing, S21, the bill on social media, cell phones in schools, the bell-to-bell concept for folks. And I know there's a lot of interest in that bill, and it's critically important, to look at just in terms of kids' mental health. So we'll look at these bills. There's no way we're going to get all or even some out before Friday, but we do want to set the stage for things that we can do. And then there's also the last one, I think, that is the competitive food bill for school foods for kids. That one also interesting and important to us. So those are the things we have. Kiki is trying to schedule what she can with alacrity and as well as she can. We want to hear about everything that we always want to hear everything. There's so much to do and so little time. So we'll do that. And I did get a message from Blue Cross and Blue Shield, the other day. I am, the Blue Cross and Blue Shield does have a couple of suggestions regarding the committee bill. I want to make sure that we're focused in on commercial insurance when we're looking at, Green Mountain Care Board, reference-based pricing for hospitals, and that's accurate. So there we are.
Okay, Jenny, the one thing we heard Friday before we went home was from the primary care providers that have been receiving global payments from the ACO. And they're very concerned about what's going to happen to them. We've got hospitals that are taking those payments. And I'd like to get an answer to that. They've been working with us in good faith. And I think we need,
Sure, yeah.
where's the money?
Yeah, well, that's the whole point in having that conversation regarding ACO. And we'll see what we can do. We will have Green Mountain Care Board, just and just to let you know, people have been working. No, it's really been great to see that, and I'm very thankful that people have been working very proactively to help us put a bill together that is going to move us forward in each area. And I know the AHS and Green Mountain Care Board have been working together. I know the hospitals have been working together. I'm very thankful for that. We all need to be thankful for that, because we've heard that there are good things in the bill, but the details are what matter. We need to make sure that we get the details that are right. Not everyone is going to be pleased, but we'll see what we can do. And I do know that primary care is one of our significant goals in the bill. Your comment, Senator Dillingham. Thank you. Okay. And if there is, I think I'm looking at Mary Kate Molman. If you have comments that you want to make sure we get them in writing and let Kiki know. Our time for testimony is like nothing. However, it's critical that we hear from folks who have been engaged in this for long. Oh, that's that. And we have our expert joint fiscal officer. Good. Oh, okay. One of the things I've asked hospitals, Agency of Human Services, and Green Mountain Care Board for is some information about the resources they might need to accomplish the goals and the work that's in the bill. I have heard it's a lot of work and we can't do it in the time frame, but we'll try to provide whatever resources appropriations will give in order to get the work done. So that's my comment for that. Right. Okay. We are, every clock is right twice a day when it stops. So this one is going to be right tonight. So let's keep an eye on time. We are now beginning testimony. So Jen is upstairs with a bill on the floor, but she'll be back down. And Devin, you are here, and we would very much appreciate your testimony. Do you have anything in writing?
I do. I sent it to
Kiki has it, so we have it online. Good. All right. Thank you.
Thank you to Kiki, who's really good at it, posting things quickly. And thank you for having me here today. Devin Green, Vermont Association of Hospitals and Health Systems. And as I've said before, I really appreciate the effort of this committee to address what's happening in healthcare right now in Vermont. And hospitals are at the table. We want to work together on this. We feel really committed. And in sort of the spirit of succeeding, I have an overarching view and then I have detail in terms of the bill. So my overarching suggestion is to keep it simple, have adequate representation, and have process. And I think one thing that's really struck a chord, or a couple things that have really struck a chord is an immediate sort of effort, and that's reference-based pricing as a pilot project, and then long-term planning, which is the plan. So I think focusing on those and really honing in on that and creating a good process around that will go a long way. So that would be my advice on this bill. And now we'll get into, and when I talk about process, it seems like there's a little bit of a shift away from process in this moment. And it's really important to hospitals to have process, to have predictability, to make sure that their voices are heard. Right now, the Green Care Board doesn't have a formal sort of reconsideration, internal review process. And so we would request that be on the table. So we have greater predictability and process going forward. So now I'll get into the detailed recommendations. For section 1, this is a lot about timing, and Chair, as you alluded to, his timing is really tight. So having reference-based pricing as something that's in place as of October, our hospitals are working on their budgets now. They got their budget orders, or not their budget orders, but the guidance, the draft guidance a few weeks ago. So this is already in process. Their budgets are due in July. It's really difficult unless there's some sort of work that has happened behind the scenes. I don't understand how this will happen in October. So that could be something for the FY 2027. For hospital global budgets, and you'll hear me saying this a couple times, we support the AHEAD model. We're involved in the AHEAD model. That's going forward. To have something out there on hospital budgets that happens regardless of the AHEAD model, I don't understand how that works. I don't understand how we do global budgets without Medicare participation. Medicare has made it very clear that they're only participating in the AHEAD model. And so to have hospitals simultaneously working on reference-based pricing, they're going to be working on the AHEAD model. That makes sense because it would include Medicare, Medicaid, commercial insurers. That would actually change hospital behavior. Having Medicare as its own thing and then all the other payers as their own thing is just going to increase administrative burden. So we would say no to the hospital global budgets unless it's part of the AHEAD model. For the reference-based pricing pilot, we have some questions around all payers. Does that mean that we're getting at self-insured plans? Are we getting at ERISA plans? What's the scope there?
Okay.
And there's language in there about moving towards site neutrality. And we would like to understand more about that. Especially, yeah, we would like to understand more about that. And then again, we would just like to understand the process around developing the reference-based pricing pilot. Will there be input from hospitals, payers, all the stakeholders? Because we heard from all the experts, if you really want everyone at the table when developing these sorts of things. So we propose to give hospitals the opportunity to measure the impact of the proposal and to participate in development of the proposal, or the pilot rather. And my apologies, I did not put suggested language here, but I can get some to you.
Which one?
It's at the bottom of the first page.
Okay.
Our other proposal around the reference-based pricing pilot is to consider risk factors when developing the reference-based pricing proposal. So use an actuarial analysis that takes into account payer mix, acuity, and social risk adjustments. You saw in the AHEAD model that they were taking into account social risk. So we have something sort of ready to go in that space. And we think that that would make a lot of sense for the pilot. And then it would be great if Medicaid actually grew at a specific rate to create predictability for hospitals and get more towards the all payer space. Maryland is all payer in terms of Medicaid, Medicare, and I mean, now it's global budgets, but when it was all payer, everyone paid the same. And so we know that Vermont's not going to get there. But if hospitals can depend on a Medicaid, modest Medicaid growth rate, that would go a long way. And then have guardrails backed by data to ensure access to care. So this is a blast from the past. This was taken from Act 48 of 2011 and some of the triggers that were put into place before single payer was to go into effect. And this sort of showed how we want to make sure that before a reimbursement model goes into effect, that there are adequate guardrails. And the language here talks about cost containment efforts resulting in a reduction in the rate of growth, and also healthcare professionals being reimbursed at levels sufficient to allow Vermont to recruit and retain high quality healthcare professionals. So we think that these findings would help ensure that access won't be diminished during the pilot project. And then we have to figure out where we're going, like if reference-based pricing, we have to understand if reference-based pricing isn't working. So what are our goals there? When do we pull out? When do we understand that's not working and things are going wrong? And the suggested language that we have here is that the board establish outcome measurements to ensure that hospital costs are appropriate, that quality and access are maintained or improved, and that hospitals have appropriate reserves and affordability is being met. And then the board shall measure reference-based pricing against the above standards annually and at the request of a hospital. If the standards are not met, then the board terminates the reference-based pricing pilot project. So that's section 2. And that's mainly the reference-based pricing piece. Any questions there? Okay. Section 3 goes into hospital duties, and one of the things it talks about, and it also talks about in hospital budgets, is doing administrative versus direct care reporting. We understand that folks are concerned about administrative costs. Hospitals already report their administrative costs. They also already report the salaries for hospital executives and clinical leadership. And the Green Mountain Care Board does a comparison of the median salaries regionally in New England. So that information is reported. My concern with doing this administrative versus direct care differentiation is it really sets up an us versus them dichotomy. When first of all, there are a lot of people in our hospitals who are both. They are both administrative and they're direct care. They're on the floor and then they're working as a chief nursing officer. And so how are those people counted? The next piece is hospitals, and we heard this from the expert on Wednesday that the Green Mountain Care Board brought in terms of lowering costs. You really need
One from Ohio.
I think so, yeah. He was
Please.
talking about getting.
Yeah, I haven't looked
Medicare.
at it yet. Yeah.
No, I listened to it.
Yeah,
It was
and-
interesting.
A really big piece is culture, right? And having a good culture, ensuring that everyone is on equal footing. If you're setting up this dichotomy of admin versus direct care, it just sets up one is more important than the other. And I don't think that's the direction we want to go in. I think the quality improvement officer, the compliance officer, and the nurse, and we need all of them in the hospital. That's how our hospitals run. If we want to work on improving our cultures, I don't know if this will help. And so that's why I caution against that. The next piece in section 3 is a uniform system of accounts. And, you know, you may want the Green Mountain Care Board. My understanding is the Green Mountain Care Board, I think back in 2018, utilized $260,000 to build this adaptive program that is supposed to do this thing. It's supposed to do this uniform system of accounts. They have had it so that hospitals go in and put in information in individual fields. It's supposed to standardize things. They've used it in the past. I believe they're still using it. And so I don't want to build something on top of something that's already.
So use an existing system and.
Yes, use the existing system. So I would say that they should build off their current capabilities for hospital budget data standardization. And that's section 3.
Oh, okay. Yeah, so, right, I think Dr. Kane's comments were more relevant for the audit, but she did suggest there was certainly data available. Okay.
And then section 4 is the budget review for hospitals. We support the statewide healthcare delivery plan being used in the budget review. There's a provision in there that asks the Green Mountain Care Board to consult with AHS to ensure compliance with federal requirements regarding Medicare and Medicaid. And I'm just not sure what that means.
Which one are you on?
It is in section 4. You're in the bill.
Section 4 budget review. And the first thing is on the adding the state plan, and there's number 2, and then number 81.
Yeah, it's in B2. It's on page 8.
Okay,
So it's the statewide healthcare delivery plan, and then consult, and the second part of that is consult with the Agency of Human Services to ensure compliance with federal requirements. So maybe that's
that just
Out
to
of my
make
hand.
sure that, yeah, it is out right. That's exactly right.
but
unfortunately, we're not
but it'd be great to see an example from that or to understand what that means.
better, you would rather, like to have it worded differently, that's all.
Or just I'm not sure what they mean there, like maybe
It means that we're in compliance with federal requirements whenever we're dealing with Medicare and Medicaid.
okay, but AHS already does that, so I'm not sure why the board has to oversee that.
Well, we'll talk about it.
Okay. And then we support incentives for hospitals to support community-based, independent and non-hospital providers. We think there may be some providers who, we are neutral on it. If providers don't like it, then we don't have to do it, but to the extent that we do support our community providers, is what I'll say, and incentives to help them. And then again, the sort of admin versus the compensation piece is already reported. And the Green Mountain Care Board has the information that it needs there. So we do not support executive clinical leadership based salaries versus the lowest paid employees delivering health.
So I want to ask a question there, because it has really been a hot button out in the
I
media,
understand.
and people are extremely concerned,
Yeah.
particular for our largest healthcare providers. So it is a big concern. For us to be silent is probably inappropriate at this time. So there may be a way of saying this that doesn't cause cultural divide. And so, and it may not be administrative, could be something else, but we do need to allow for the board to have some look at this and some response.
Doesn't the board have that authority now?
Yes,
I don't know if it's explicit.
it is. I mean, they look at all the executive compensation. They get
Do they have the authority to make change within the budget relative to that?
they have authority over the budget, and they have done things to OneCare executive compensation.
Well, so we'll talk about this one, but just so you know, it's not even with what the board can do now, we are seeing the response publicly. So obviously, whatever's there isn't solving a problem.
Mhm.
So just between us, chickens right here, this is,
Yeah,
so just think about that.
yes, I will think about it, and we'll see, we'll see,
Yeah.
a way that's not administratively burdensome either, like.
No,
Again,
we understand, you don't want to go right down to the person who's teaching, part-time, 3/4 time clinic and 1/4 teaching, and another one is the opposite. So,
Right.
yeah, we
or
got,
like a medical assistant.
Yeah,
They're not
yeah.
direct care, they're helping the
We get it.
provider, but providers want their medical assistant.
Yeah, exactly.
So like,
exactly.
Yeah.
No, and those are key for delivery. For,
Yeah.
Delivery of services.
There's a difference between the board having the power and the board choosing not to use that power.
Right.
And if it's there and they can do it.
If they have that power, we need to know that, right?
Yeah.
Yeah.
Jen could probably tell us that.
I just wanted to echo, what the chair said, my constituents are really concerned.
Yeah.
I'm getting a lot of, communication from them. And, I would argue that already the culture is suffering a little bit, and that it would actually be helpful to be able to rein this in, and put some guardrails around it.
you may be thinking of one hospital.
Yeah, that's what I'm thinking is
That's
we have
right.
one hospital
Yeah.
You got
that
it.
stands out, but you might do harm. To what have we got? 12 others? I mean,
So there needs to be board discretion with this?
Right.
Yeah, we get it. But we don't want board discretion to the extent that it allows for a top-heavy environment that we're seeing now. I mean, it's delicate, right? I'm looking
Well,
around at
that's-
Jen, and we'll come back to you, Jen. Okay, this is a nuance.
Yes.
Got it.
The budget shall be consistent with statewide healthcare delivery plan, including total cost of care targets. We support this. In order to move towards total cost of care, we think it makes sense to move away from the net patient services revenue target. We've seen how that has been a difficult metric recently, because net patient services revenue is the actual care that's being provided. And if we're moving towards total cost of care, we definitely support that. We would like to see the removal of the net patient services revenue, and that would help ensure access to care as well.
Yeah.
Okay.
There's a global hospital budget piece in here again. I'm not supportive of the global hospital budgets without the ED model. And then outcome measurements to ensure that hospital costs are appropriate and quality and access are maintained or improved, and that hospitals implement their budget orders in a manner that is consistent with the healthcare delivery plan. We support this with consistent measurements year to year. Boggs has actually put forward a proposed measurement structure that measures finance, quality, operational effectiveness, and access to the Green Mountain Care Board. We're really looking for predictability and not for measurements to change year over year.
Which bullet are you on?
Great question. Now I am so wishing
I'm on page 3 of 5, but I'm
yes,
finding myself. I just lost.
from my testimony.
Yes.
Right in the middle of the page.
Statewide healthcare delivery.
Oh, sorry, and then a little bit, the outcome measurements is at the bottom. Or, third.
I got it. Okay, thank you. We're good. Keep going.
Hospital reduction or elimination of services requiring a notice of intent to the board. We just need more process around this and understanding of what the process. We've seen that Rhode Island has this in place. They still had adverse outcomes with the hospital closure, even with their process. We just need to understand how this works, and how finances will be administered while the hospital's in this process. So if a hospital were to close and they have to give notification and go through a process, what is happening there? Are they being subsidized? Or if they're eliminating services that are needed, are those services being subsidized? What's going to happen? And then at the very bottom, of page 3, board shall monitor the decrease and connect it to health insurance fee premium. So if a service is eliminated, the board would connect it to greater affordability and health insurance premiums. We support that proposal. We think
Let me hold that thought for just a second, but Jen, did we take out the reverse DON?
Jennifer Kirby lives in Pennsylvania. No, I think we still have, yes, on page 12, the hospital that proposes to reduce or
Okay,
eliminate any service. That's sort of
Got it.
being referred to as the reversing one, but it's
Got it. Okay.
okay, we're almost at the end. Thanks for hanging in there with me.
No, you're doing it. This is good. Thank
Okay.
you.
Hospital network, financial operations. I'm not going to weigh in on the oversight of a health network, but I am concerned about the language in there that in section 5 that allows the Green Mountain Care Board to take appropriate action as necessary to correct the hospital network's operations that are inconsistent with the principles of healthcare reform. That feels very broad. There's no process. Essentially, the Green Mountain Care Board could go in and close down a network with no oversight or process around it. So we would want certainly a process there, criteria, avenue for appeal, definitely needs to be fleshed out more. And then 6 and 7, the statewide.
Just a comment there.
Sure.
I mean, I think our concern is looking at when you have we have patients in Vermont who are going to New Hampshire or New York, or Massachusetts, that Vermont dollars, public dollars follow patients, and we're just trying to understand the flow of funds, ultimately. So the language here is, probably more than the intent.
Yes. Yeah.
Right.
Yeah, because we do have to think about future
Yeah, we do.
future action too. Section 6 and 7, the statewide healthcare delivery plan. Again, we support this. We really appreciate the role of the advisory committee in this process. I would say the thing that we would change is, in Vermont, we're a state that can actually get all the stakeholders to the table and it's not completely overwhelming. I really think it's important to get each sector in the healthcare system at the table. If you somehow end up with all primary care providers or all payers, that's not going to be a fully comprehensive plan. You need EMS. You need someone who says, doing this in this part of the system is going to affect nursing homes this way.
You get it.
So I would really advocate for, representation of all sectors there.
So when you're looking at you're looking at the members of the advisory committee, it would be helpful to have some recommendations on that. That was, I won't tell you how that came up, but it did. And it would be good to improve it.
Okay.
Good.
Happy to do that.
Sounds like adding EMS as well, right?
Yeah, I mean, I would say we have done things in the past where it has said, you know, there is someone that the medical society puts forward, there's someone that, you know, so
Yeah.
I think we should go from there.
Okay. Well, any thoughts that you have there would be helpful.
And then, for the statewide healthcare delivery plan, I also think it's really important to define affordability. If we have to have a goal to know that we're reaching our goal. And so we would advocate for a definition of affordability to know what we're striving for, what we're trying to get to in that space.
We're striving for prosperity.
That's a new.
That's about as in the eyes of the beholder. It's like fair.
Section 8, integrated system of clinical and claims data, VAS supports this. Section 9, exploring and retaining the capabilities of home care. VAS also really supports this. We don't want to lose ground. And then section 10, additional agreement care board positions. As we mentioned before, we do not support this. The Green Mountain Care Board has about over $900,000, almost $1 million, that they can reallocate from the One Care oversight going away. Hospitals start funding that money. That provides resources to the Green Mountain Care Board to do this work. And the Green Mountain Care Board has presented comparisons to other agencies. But I would argue that these are not direct comparisons. So they've looked at, you know, the Public Utility Commission and the Department of Public Service. But the Public Utility Commission is really the regulatory body. The Department of Public Service is more like the healthcare advocate in that space.
But they do provide data. I mean, they do have.
They do provide data, vital,
Yeah.
but you know, there's a lot of data
Yeah.
provided in outside sources to the Green Mountain Care Board. So I think the Green Mountain Care Board is actually pretty in line as far as a regulatory and policy body, and as far as the amount of population that they're representing.
So you are going to be in direct conflict with what the board is feeling that it has a huge amount of work to do in this bill. And
So the hospitals.
and for the hospitals. So,
Yeah.
and my question of the hospitals, actually, I don't know if you don't. But the question about resources and allocating resources to AHS and or to the board will be important to help hospitals. So let's think of that in another way, but also, and then some of the need here is short term. So we'll see how it goes.
Yeah.
I hear what you're saying, and I do hear what you're saying about the $1 million from One Care, but we also hear from primary care providers that that's money that goes to supporting their services. So
I would say use the $1 million from One Care and then use the 15 positions for primary care.
in what way?
I mean, you can take those positions, take the budget for those positions, even just the 5 positions, and put it towards primary care. You can match that with Medicaid.
Okay, well, we'll think about that. We haven't looked yet at what the whole ask is. The money that's in the bill came out of some of my thinking about what we might need, when, where, and how, so. Yeah, that's not accurate. I will accept the responsibility for the inaccuracy.
And that's all I have. Again, I would just stress, let's really focus on the things we can do going forward, which I think is reference-based pricing pilot and do it well, and then planning with a lot of representation, and ensure that there's process throughout.
So when you talk about, let's go back to the pilot, that was the first thing that you brought up, with the reference-based pricing. And when you are thinking of that, you're thinking about the Green Mountain Care Board identifying a single hospital to put in place reference-based pricing to lower hospital costs. Is that what you're thinking about?
I think what we've heard from the Green Mountain Care Board and payers and providers is that we can't do reference-based pricing all at once, and at a large amount. It will decimate the system. So we need to do it carefully. And so if the pilot is certain services, if it's certain, I would need to understand the, again, this is why we would like to be at the table to understand what
What it is.
is.
Got it. We understand. And I know in looking at what Rutland does with its reference-based pricing, it's not everything. I get that. They have part for some services, so on. And each hospital is different. And it may well be that ends up being what falls out of all of this. So tomorrow we're going to hear from someone about payment reform generally, and how does that fit or not fit with reference-based pricing. There's a lot here. I think, remember, the one goal here is that, and if you're talking about a single hospital initial, I don't think of it as a pilot. Well, we're going to learn from it regardless of whether we call it a pilot. But I think of it as a real important opportunity to bring costs down, period, over a 3-year time frame. And the way it is in the bill, it sounds like it's too soon. So maybe it's the next year, but something has to happen. Something has to happen in 26. Something has to happen right away. So it may not be this, but it's something I know Green Mountain Care Board and AHS are talking together. So we'll see what it could be.
Well, I've been around long enough to be leery of each year's panacea or catchword that's, and this year reference-based pricing is going
isn't
to
it?
solve all our problems. But the fact is, we don't know.
Right.
It's theory. We have one hospital that is very expensive, and then we have everybody else, and we're told everybody else is in the red. And so the question is, if we're going to do reference-based pricing, and the goal is to cut what we pay them,
Might be increasing somebody.
well, see, it might. But I think what I'm hearing from the hospital is, okay, we'll go along. I don't think anyone would object if you wanted to do it to the big guys, but I don't think they're gonna be it. When do we know this is not working? I mean, how deep a hole
That
are we going to let them dig themselves into? What's there to dig them out, and who's making that call? Because I don't think we've heard testimony that everybody has a huge gap between administration or is heavy in administration.
no, but it could be the other direction where we're seeing hospitals in the red. And by increasing the amount they get paid can help. So it's a
Anybody
rebalancing.
Getting paid less than
Yeah.
a reference.
I mean, we don't know. We don't know what it is.
We don't know.
It's
No, we don't.
part of it.
And we're not the regulatory
Right.
group.
We're just saying we need to be there to let you know
Right.
what.
Is happening.
We got
The goal
what the
isn't
efforts
to
would be.
put a hospital under.
Not at all.
Right.
The goal is to, and that's why it's built in with the plan in place. So with all the transformation work that's currently going on, yeah.
Could we, I don't know what transfer
I know, and
work is going on, and
I'm very excited about all this.
I might be if I knew what it was. And I doubt Senator
No,
Luke
what-
might know, but I'm pretty sure the guys on the
What-
other
what-
side of the
what
table don't
is?
know any more than I do.
What is? I want to know what your what is. What, you don't know what is.
What, we keep being told that we're doing hospital transformation. But I don't know what that means. What are we transforming them to? Or are we just transforming their payment system? Or are we transforming the care? Are we
Yeah.
transforming them to a global budget?
So,
I mean,
yeah,
that's
these are all good.
just to get a refresher course, so
Good.
when we throw out that word, we all know what it means.
Do you want to talk to that? I mean, I know there's a lot going on. So we've got a couple of minutes and it would be helpful to
Right.
hear what you see is going on with hospitals.
yeah, and I'll just say again, a lot, yes, so a lot going on, the Rural Health Redesign Center, which, implemented global budgets for rural hospitals in Pennsylvania, are working with all of Vermont's hospitals. We've all signed up to work with them.
So we're transforming to global budgets.
So no,
That
here,
is the plan now.
Okay, that is the plan now, all right.
So that was the plan under Act 167, transform to global budgets. And so the idea behind global budgets is you get a certain budget to work within, and you get a lot more freedom to get rid of orthopedics because now you can do substance use disorder because you're not having one subsidize the other. through
Okay, so it
fee-for-service.
takes away the difference between procedures or services you make money on and services that you lose money on. The individual hospital gets to make those decisions. I'm assuming with somebody making sure that dialysis is available
Well,
somewhere.
and so let me stop. Yeah, we're gonna get to this conversation, but
Okay.
so yes. And when AHS comes in, these are the questions we should ask of AHS because they did hire the contractor who worked with hospitals and to look at how hospitals can A, work together, or B, to change their service delivery systems so that they are more, they do make money and they're not under, getting into the red. There's no goal of closing a hospital. There is a goal of ensuring that regionally, the state has services needed by the communities. And so that's why when Brendan Krause comes in, he talks about transportation, getting people to the care they need. So that's what is happening out there. But in the meantime, we have the payment issue and the planning issue. So now we can start to build from what's going on in the transformation process, what hospitals are doing together and with community services, with AHS and others. What's happening out there could be built into a plan that then says, these where these services are available, they're accessible, and that'll change. So that's why you have an advisory committee to look and say, oh, this is changing. And in 2035, we need to do this because we didn't need to do it in 2030. So there's a lot going on. And we're trying to set up a system. And I think we heard this very clearly from Elliot Fisher. You need a system that is flexible and will change going forward. So that the gear, I don't know what he called them. But anyway, so yes, you're right. There's a lot going on. And I think the bill does help to take us that next step. And it does rely on cooperation that we've been seeing with everybody working together and make it happen. So that's 2 cents there. Anyway, we'll come back to this. And Senator, when AHS is in, ask your question again. It's an important one.
And I think beyond global budgets, they can help with, you know, making hospitals more administratively efficient and other things.
Oh, good. Any other questions for Devin? We see, thank you for organizing it the way you have. This is really helpful, and we'll be able to go through. There might be language clarifications that will, given us some. That's good. And then we'll take this into account as we hear from others. So let me ask you one final question. This represents all hospitals?
Yes, this represents. all-
And who else? Home health services.
No, wait. Bill Olson would kill me. No.
Okay. So-
What are you trying to do? Get me
No, I wasn't
in
trying-
trouble with
Just saying,
Bill?
all you have to say is no.
This represents hospitals.
Thank you. That's very helpful. All right, we're good.
Thank you.
All right, thank you. I still don't know what time it is. Oh, we have 14 minutes. Jen. Yes. I think committee, would it be helpful for us to take a little walk through again of the bill so we know who we are and what we're doing, and maybe a comment or two about what we've heard? Is that a good thing to do? I'm looking at my committee.
Ready, Bill?
Do you need to go through the committee bills? Don't need to.
I got a boy.
You know where you are? Okay, that's good. I'm gonna ask Kiki. And before I'm gonna ask Kiki, is Sharon Goodwin available prior to 11:45?
She was gonna be in person.
Oh, she is, okay.
I know.
So that before we move on to Jen, you have something you want to share with us?
No.
I'm looking at folks who are in the room, and I include, Sarah, you're here, or Mary Kate, is it, who else? Anyway, if you'd like to make a comment,
I will hold off on my comments.
okay? Did you want to add?
I'm happy to comment. Sure.
Okay,
Let me
good.
just pull up what I sent.
Yeah.
I can't
Yeah, good.
remember my comment.
I don't have it in front of me either.
Maybe we could talk about some of the comments we heard from the hospitals and then let Jen know if anything
All right.
heard.
All right, Sarah, put yourself
We
on
can,
hold.
well, we can hear from Sarah.
Yeah,
too.
no, you're good. You want to
Because-
hear from Sarah first?
Yeah, because
Okay,
then
let's do that.
we get at least the comments and then we can, because we've only got 3 days.
Yeah, I know.
Right?
3 whole days.
3 whole days.
Wow.
You know, old days.
Be surprised.
So Sarah, well,
Very short.
Thank you.
for the record,
For the record, Sarah Teach out with Blue Cross and Blue Shield of Vermont. My comments were specific to the reference-based pricing sections of the report. We have no concerns with what you're trying to accomplish, just trying to provide some suggestions about the way you organize it and language that would perhaps make it work better. So one of the concerns that we had is the way the language in the first piece of it talks about the board establishing reference-based prices that represent the amounts that payers in this state shall pay to, and it uses the term healthcare professionals for services delivered to Vermont residents. So our two concerns are we don't just pay healthcare professionals, we're actually paying hospital facilities, which is, I think, the main focus of reference-based pricing.
The definition in the chapter.
Okay,
Broad definition.
yeah, so we pay across service lines. We pay for inpatient care, outpatient care, and professional services. That's how we pay for hospital services. So this Jen may be absolutely accurate, but it struck me as a strange way to do it. And then also the restriction that this only apply to Vermont residents. Blue Cross and Blue Shield of Vermont pays for our members and our sister Blues organization members who visit Vermont hospitals and other healthcare providers across the state, and the current hospital budget orders apply to all of those numbers. So just singling out Vermont residents appears also to not work for the way that we would do this.
Okay.
We have concerns again. There was a section 2, you talk about keying off Medicare rates. And we would say that there are some services we pay for that Medicare either doesn't pay for or doesn't have a rate. So we need some sort of way to handle that in the statute. Or the Green Mountain Care Board does. So just a little flexibility there. And then we agree with Boz that hospital fiscal year 2026 is approaching pretty quickly. I'm speaking for Blue Cross and Blue Shield of Vermont. I don't think that we have to update our IT systems by a module that does reference-based pricing, work it all out. So it's too quick for our organization. I can tell you that. Yes. And then, where you talk about non-hospital services, and again, this might just be wording, but we actually pay for services delivered, the same service delivered in a hospital and outside of a hospital. So I was confused about whether non-hospital services were just services at independent providers, or you were trying to expand it beyond services that may not be delivered in a hospital setting. I think that's what you're trying to do, but clarification there would be helpful. I also am not sure if you're trying to do this in the same fiscal years you're trying to do the reference-based pricing for hospitals. I would suggest perhaps staging it and making sure that we can do it for hospitals before we go across the whole system. And the other point I had to make there is I'm not aware of any state that's on reference-based pricing outside of the hospital system, but doesn't mean we can't do it here in Vermont.
Well, yeah, looking at what Medicaid does, I guess.
Yeah, and I guess the last point I wanted to make is, we have what we call a community fee schedule. So we apply consistent pricing outside of the hospital setting. So we don't feel like there is as much variation, at least for Blue Cross, for services outside of the hospital setting. And then the last question I have for you here, jumping around a teeny bit, but back up, you talk about increasing based on Medicare rates or not Medicare rates. And then there's a whole section on trying to, I think it means give higher prices to things that we value more. So that, primary care, mental health services, that's fine. I think the other thing that we don't know if is meant in here is, would you pay different hospitals different reference-based prices depending on the kind of hospital they are? Just a question. I don't know.
That's probably the answer would probably be yes, I would think, wouldn't you? Yeah.
Yeah. So I'm not sure if that's contemplated in the way that
Right.
the language.
And part of that will be a decision through the board process.
Right.
Yeah.
So we felt like some of this language was a little too restrictive of what the board is trying to do.
Okay.
Others maybe not clear enough. So we recommend giving the Green Mountain Care Board some guardrails, but allowing them to develop the reference-based pricing structure that makes the most sense.
Thank you. No, that's helpful. And I think that's exactly why we say, the devil's in the details, and we're trying to get to the details now to fix the language in a way that works. Thank you.
Thank you.
Oh, that's good. And we have, did you send this to Kiki?
I'm gonna put it in a little bit.
Okay, yeah,
Fix
that
the
would be
spelling
good. I do
mistake.
have your email. It would be, sure, if we can get it, and then the committee will have it as we go through. That'd be
Okay,
great.
happy to do that.
So I'm gonna take one more deviation because Sharon Goodwin is here early. And Sharon, if you could, welcome. And we're gonna put you in the witness chair early, and then we're going to have you give your testimony, which we have online. Thank you. And then we're gonna stop after 15 minutes and 10-15 minutes, and we're gonna go to Jen and go through some of the things we've go through the bill with an understanding or a beginning understanding of what we've heard from witnesses this morning. This is a good way to go. And we'll start out with that on Wednesday morning at 8:45. Okay. Welcome.
Yeah.
Let's introduce ourselves because you don't know everyone around the table. And
I've watched you guys.
I'm sure you have. We haven't watched you though. So
I'm the newbie. You are, to me, you're top dogs here.
Okay, so let's start over here.
Senator Larry Hart, Orange County.
Sam Rose from Oldings County.
Nice. Ginny Lyons.
Hi, we're Team Oracular, Chittenden Central.
In Cummings, I have the Barry Rehab Gym in my district.
Okay. So thank you for coming in and bringing testimony, and I'll just let you go right ahead. We have your testimony here. So,
Right.
I'm looking at the patient PT payments versus inflation.
Yeah, first, Sharon Goodwin, I graduated with a PD degree from UVM, and I worked at what was Mary Fletcher de Gosbriand. So I kind of evolved with the hospital. I then worked at a private clinic owned by Fanny Allen and a private investor. His name was Jack Spratt, and it was really Jack Spratt. And then the independent ortho group that was called Sports Medicine, who are now at City Drive. The independent orthos started this PT clinic because they weren't happy with hospital-based PT. And when then it was Fletcher Allen took over Fanny Allen. Yeah. Whatever. Fletcher to those. And then they took over the doctors. And then there was a hospital takeover, and SRC basically dissolved. And the business of the rehab gym was, I believe, the fourth of the businesses launched. And mine launched in 2003 from the hospital absorption. The rehab gym grew rapidly and is now the major outpatient PT provider in Vermont. I did get the Vermont Small Business Person of the Year in 2008, and it's received nationwide attention, even from England, as being innovative in using PT proactively. It is not a traditional PT clinic, but a medically oriented gym in which physical therapists practice along with people who come in for preventative care. Our customers have had direct access to both rehab and preventative care, and I'm most proud of the lives we have brought from ill health to health through empowerment and fitness. And the lives were transformed not just in health, but a ripple effect through their family and social structure. So it includes mental health. So that graph that you see, the top line green, is the rate of inflation from 2008, where we were profitable. And the profit was enough for me to expand my business. So I wasn't complaining. It worked for us. And that's a year-over-year rate of inflation since 2008. The bottom four lines are actually from one payer and in 4 codes. And it happens to be one of my higher payers. So you can see how it was level, and we were doing fine until 2015. Obviously, the profit margin dropped. Growth went to a stalemate. Even though other cities in Vermont wanted me to come, I knew that it wasn't going to be wise. And the money that I built that was taxed under my Social Security is what has allowed me to stay to today, where we are still down like 30 to 40% in what we are making compared to our expenses, because inflation is expenses. Oh, it's not up there?
No.
Yeah, you can put it up.
You can put it up if you have to share. Can we?
Oh, I thought Kiki was going to key it in.
No, share.
Okay, then let me figure out how to
give
do
you a
that.
screen share. You have to go up on Zoom. You go to the Zoom, and then she'll give you screen share once you get there. And make sure you're muted. And then you'll be able to put it up.
Okay. I need to get to Zoom.
Maybe Kiki should just do it remote.
Huh?
Oh,
No.
that's true, sorry.
Apologize. So I probably, do I need to be connected though to the internet?
Yes.
That's what I wanted first. Wi-Fi, And it's on, and it's public. Okay, we'll go back to my Zoom. And continue. And do you want me to do, just share screen? It's gonna get all my notes though, so it's
Well,
not.
put your,
What's the key?
Send you an email with the link and you can just click that.
Oh, okay. So you guys, okay, I don't jump in, and then I can go into screen share. Whoops.
Maybe be ready for the next time.
To a third party, it's fine. Come on. Should I just hand this to you, Kiki? Why? There. Seem to get my instructions. Here we go. So I went to share. It's here. Oh, here we go. Screen. Finally. Everything on your screen. That's fine.
You get your testimony up and then you share screen.
Yeah, well, my testimony, I decided to do my notes right in the body of my testimony, but that's all right. You've got printouts.
We're looking at your graph and we'll listen to what you have to say.
It's everything on your screen. Do not disturb.
You want screen broadcast?
You are sharing screen. Okay, then I can go back. Downloads. You see me?
Now you just make it large.
There it is.
And then if you get rid of the
Yeah.
sidebar, you'll be set. Although it doesn't matter.
I don't know how to go through that.
That's okay. Just,
Yeah, let's just go. Oh, here we go. Okay, I already did that.
you got
Okay.
it. You got it.
So, but future survival is not possible in a system rigged to favor a hospital system at the cost of independent providers. I'm confident that healthcare costs can come down. I really am. But it will take a major shift in legislative understanding and action to protect what is working and affordable and accessible. So we need to recognize the difference between critical care and outpatient care. Hospitals used to be just critical care, and they have encroached quite a bit on outpatient care. And it used to be 70% independence and 30% of the providers working for a hospital. That is actually flipped. So now what we've got, and it's continuing to deteriorate. In other words, hospitals, and it's not just one, it's all of them are migrating. So UVM is no longer a hospital, but a mega hospital system. It's not one hospital. And there's no solid evidence showing that a merger acquisition of independent businesses improve quality or affordability. The expectation of more efficient, lower cost healthcare, like an economy of scale, has not proven possible. There is a number of explanations, reasons, excuses for the continued escalation of costs, but none really truly pan out. And the furtherance of entertaining the explanation only exacerbates what is now a dysfunctional part of our healthcare system. And I left a link so that you could look that up. We need to recognize that hospital systems reduce competition, which is a major factor in the advancement of the health of any industry. By direct capture and keep of patients, which we have going on strong in Chittenden County, higher payments result in lower payments to everyone else because there's one pie. And it, trust me, I'm all about motherhood and apple pie. And we're talking about a hospital, which I love dearly. But the mother is eating the pie. Higher payments mean higher salaries, and that's unfair. We can't compete with what the hospital pays their providers. And eventually they absorb or force out the businesses that they compete with. Reduces innovation. Innovation happens, this is actually a quote, more frequently in small businesses compared to large corporations due to their greater agility, closer customer relationships, and faster decision-making processes, and a higher willingness to take risks, allowing them to adapt and implement new ideas more quickly than larger companies with more complex structures. We know this well in the tech industry, where, you know, Steve Jobs was in the garage and he overcame what IBM was doing. So RG is a great example. I tried to do, even within the SRC, to get this going. As an independent, I'm able to test the waters where hospitals can't. Reducing patient choice, that speaks for itself, increasing prices. There's no hospital system that has ever shown an ability to lower costs. We need to recognize that the hospital systems possess the financial resources and power to influence, control, legally challenge authority, making regulation difficult. This makes your legislative job even more important because this cannot be done through regulation alone. We have seen this with UVM's response to regulation with lawsuits. And we have to understand that the Green Mountain Care Board, is tasked with ensuring our healthcare system provides quality, and this is direct, affordable healthcare to all Vermonters while reducing waste and controlling costs. It is not to be a tool for sustaining any part of our healthcare system that threatens the whole of it. The purpose of regulation is to make sure that a large business does not do harm to the industry they're a part of, and the public depends on regulation for this reason. The legislature and previous board members were warned of the danger of allowing UVM to expand and overpower the healthcare system. The canaries in the coal mine have not been taken seriously, or I should say enough, because you guys take it.
We are taking it very serious.
Okay, I know. Well, now we're at the
cliff.
cliff. Okay, we're at the cliff. The few independent practices that remain are near the end of existing, and I am not exaggerating. And frankly, if it goes under, I'm free, you know, go to Costa Rica. But Vermont can't afford to lose more of us. The loss of the pillars in healthcare will lead to a collapse of the entire system because hospitals are not capable of providing what community providers have at the same level of efficiency and affordability. And UVM itself, it's unsustainable as a system. Healthcare should be directed towards most accessible, affordable, and effective. And it might be that this hospital needs to divest. I know that I'm probably saying things you've not heard, but trust me, this is the conversation that is going nationwide because their size is the biggest threat to their solvency. So solutions, because I really am all about solutions. I'm not a complainer. Shifting care, hospital services, always most expensively successful, means we need to think about them staying with critical care. It doesn't make sense for all else. You've heard the hospital treats more complex patients, and while true for some, it's not true for the majority of outpatient services. The Green Mountain Surgery Center, Open MRI, PT clinics all see the same patients with the same array of payers and percentages of each. I showed this to the board. They don't treat more Medicare or Medicaid. Patients at higher risk are typically identifiable and should be treated in a hospital setting. But why not direct healthier patients in reverse? An enormous profit margin means money goes somewhere else other than to treat those patients' care. And that raises ethical questions. I've had many patients not even aware that they were in a PT session until they got a bill for $500 for one. And most outpatient services can be delivered in independent locations. Quality, accessibility, and price are all shown to be at least equivalent, if not higher. Independents refer high risk, we refer high risk patients to hospital. Hospitals should be referring non-critical patients to lower cost options. At least have a discussion. And I've never heard any patient given an option. If we all truly care about the expense of healthcare, this is an obvious consideration. It appears we know what the hospital is doing, yet turn a blind eye to it. How do we do this specifically? We need to prevent further erosion, and prevention is the key, incentivizing businesses that keep people out of hospital. We all are in agreement of that. So specifically, I know that you're not here yet, but site neutral pricing is the only way to eventually get there. It's a nationwide trend. It's been going on for years. CMS is behind it. Blue Cross and Blue Shield is behind MVP. Everybody's behind it, but the hospitals. That should say something. So no one should have to pay more for healthcare because of where they receive it. The cost of routine healthcare services, PT X-rays, colonoscopies are significantly higher when they're provided in a hospital. This has exacerbated the trend of corporate hospital systems buying practices to give them great negotiation power to charge higher prices. They're in a spiral, which premiums for patients, go out. So that's a quote from Blue Cross Blue Shield, somebody in it, not from Fund. In addition to insurer support, it's also got employer-sponsored health plan support, dozens of lobbying groups. But you're talking about hospital systems that have a lot of wealth and power. I am thinking it can be done in steps. And just like reference-based pricing, we don't have to bite off the whole thing. And this is actually simpler. Start with low complexity services. In my profession, PT, we really only have a handful. We have 12 codes at most, 4 we use most often. And it doesn't matter where it's delivered. And I'm sure with OT the same, speech, nutrition, psychotherapy, these are the key workers within the primary care setting. It's not the MDs who measure to see health. It's their tools, and their tools are us. So with few billable codes, you don't need to have a big complex change. And it's not going to be monumental for the hospital to start to accommodate. And we can test the waters, right? What happens if this happens, and measure the return on that investment of effort. It is assumed, though, it's up in the billions from just that alone, because I don't have maybe the quote is there of this was actually done. I think it's $1.3 billion. Okay. Reference-based pricing, I won't get into that a lot because I know you just had it. I'm just going to say that it is more complicated, and you've heard now it can't be done this year. I question that even. I mean, again, if it really is wanted, there's ways to make it speed up a bit, because I don't know that time is any longer on our side. I just heard Blue Cross Blue Shield is going to go up in premiums again. So I will tell you, though, the rehab gym on average is 113 reference-based to Medicare. UVM is 358 according to the RAND report, and it's 382 for physical therapy. That is what we're facing. And it's not just the business, it's the patients. Now, Indiana bill did pass in the House with a wide margin, 68-26, and it's now in the Senate, a reference-based pricing bill. And I'm thinking if it's 68-26, they'll probably get it passed. I heard that no state has. They might be the first. And it's interesting because it caps hospital. They started at 200%. They went up to 300% to get something. And nonprofits forfeits their status if they go over, and requires annual audits and reports. That's the thing. This requires a tremendous amount of work to try to police, but it's better than doing nothing. Possibly the larger hospitals, the more complexity in maintaining financial clarity. That's another problem. I have a list of subsidies, tax breaks, hidden fees. Hospitals revenue is so broad. And to really understand how it all works, you have to dive in. And I remember listening to you, Ginny, to ask about transparency in the hospital. We need transparency. They're not even getting pricing very well. They did have that 2 years ago. That's gone now. It's not readable anymore. So transparency has to be diving into the intricacy of their finances, how it all comes together and goes out.
Where's the list?
I have it with me. I'll leave it in paper form. I could also email it. So, look at the list to see what you could do with transparency. And more, but no, more knowledge alone doesn't drive change. We've known for decades the difference in pay. How much? It's just a lot, and it's enough. Okay, so push to quality care. Also, there's a big push. Understand this. There really is no good definition of what is quality. And it's not the public outcry. Public outcry number one is affordability, and second is accessibility. And trust me, we have to trust the providers. We need to step back out of the relationship between provider and patient. We've got too many influences coming from payers. And, you know, within hospitals, what I'm hearing is providers have to follow the systems of the hospital. So that is pretty much the end. I'm just going to say if hospital prices continue, I don't need to say all that because, you know, we're at the cliff. We're toes over the edge. And you're faced with many good causes to spend money on. Oh my gosh. Hats off to you guys. Oh my gosh. But legislation that is effective in reducing this one branch of your work, healthcare costs, could find money outside of taxpayers' pockets to go into these other programs. So sustainability must focus on the healthcare system, not one part of it, focus on what's working, build on that, at least don't lose it, and regulate what needs regulation. And the last bit is how a healthy healthcare system looks, where prevention, which isn't just primary care doctor's office, but the whole of who keeps people healthy in our community, recognizing getting healthy, social supports, in-home care, nursing home care on top of that, outpatient care, ambulatory surgery centers, birthing centers. And then if we can leave the hospital doing critical care, we can figure out what it is they need to be paid to do critical care. We don't know that now, right? It's all muddled. So let's figure that out, pay for it, and let the money go down to support the triangle.
We're all about it, period. Yeah. Good, no, good timing, very good. Thank you. And your comments, your written
Yes.
materials, if you feel like sharing them, would be welcome. And if you can share them, that would be welcome.
I was hoping that there would be questions because
Go ahead. Senator, go ahead.
I like graphics. I love graphics. So that pyramid, I think, is
Yeah.
really powerful. What would Vermont's shape be?
oh, good
Would
question.
it be like
I
a
like that.
rectangle?
I think what it would look like, honestly, is this. Let me show you. Yeah, exactly. We've got this happening. Good analogy, because it's not very stable right now.
Worse than a rectangle. Okay.
Another analogy I thought of is a centipede. You know how they've got 11 or 100 legs? If you start kicking the legs out, you're going to have a centipede on the ground, not doing very well.
Mhm.
So this is the the New York is actually working on site neutral. I don't have hope in it, but it's a blueprint. I don't know if you would like to see, and it's much more than what I'm recommending. I don't want to do the whole kit and caboodle. If you can just keep the primary care at the bottom alive for another year, I won't be back. I'll be back. And then this is the list. I'm just gonna,
We'll get it, Kiki, and then we'll,
so there's 5,
what makes sense.
and then this was the this was the reference-based pricing, bill, and sort of it
I
shows.
just read it. Is that which one? That's not the New York bill.
No, the New York bill is site neutral.
Yeah, I saw that.
And then, the Indiana bill is referenced, and that will probably pass. So, okay. This will even have all my notes.
Oh, I didn't get.
I'll give them to you.
Those are the people.
That's the people.
Okay, great.
Yeah, handouts. I did my own copy.
No, that one has notes.
Oh, well, it only has notes on the top, and it has something that my cat put on when he jumped on the counter.
I understand that.
Or it might be a coffee too. Okay.
Thank you. Wow.
And does anybody want my notes? Cause those you don't have with it.
Yeah, no, that would be great. If you give us the notes and we'll have them and Kiki can distribute.
Yeah.
Post it like.
You'll get them out.
This is the New York though? Oh, that's pretty online.
I mean, let me
So
just
no-
share,
no other
let me
questions?
share with you,
Yes.
Sharon. I appreciate the information and data that you're bringing us. And the background for site neutrals in particular and reference-based pricing. You brought us a lot of things that are not in the bill.
I
You
understand.
brought us a different way of getting at problem solving, which is okay. What we all believe in that pyramid. And one of the goals in this bill that we have before us is to reinforce and support primary care and community services, including physical therapy. So just so you know, at this stage of life, we are moving forward with the bill that we have, but what you've given us will really support much of the work that we are doing and give us a look at possibilities going forward.
Yeah, I'm not convinced there's gonna be any more revenue, and I'm looking at basically. my
Yeah,
personal
well, no,
finances.
there is no more. Well,
And Diva has not been any help, by the way. We saw.
So Senator Cummings,
Just something we might look at 4 or 5 years ago. You and I had a bill that didn't come off the wall, which basically said if you can't provide a service within 6 weeks. Or X, you must refer out of network. And then I have a cautionary tale. I had a constituent who had suffered a major brain injury. Ran through the PT that her insurance would pay for and was improving. And so she decided, well, it was $90 a session and she could afford X more sessions and on her own. And she wanted to do this because she was doing so well. She was younger. She had a stroke. She was still maybe her early 40s. So she did the sessions and then she got a bill for $30,000. I said, I think I can figure out what happened. During that time, the hospital took over the physical therapy. So she wasn't paying 90, she was paying that $200 facility fee. There's a little thing on the desk. Yes, she was paying $290 a session. But other than that little thing on the counter, which she probably didn't look at because she came in, went into therapy. She ended up with a $30,000
medical debt.
medical debt.
We know about that.
Yes.
Committee.
But that was the difference in the pricing differential. She was going to the same facility with the same
Wasn't
physical
site
therapist.
neutral.
And we've tried to finance to deal with this. We have a difference between in-network and out-of-network primary care providers. And we've heard testimony. And yes, site neutral might be something to look at.
That's in our bill, but it may not be as robust as it should be. We can think about it. So, the committee, I'm going to suggest that, given that it is 5 minutes of, I don't think we gain much by having Jen come up and go through the bill with us with the testimony we've heard. However, tomorrow morning at 8:45, we can do exactly that, and that will give us a little time to go through what we heard today and go through the bill And we'll come back with Jen tomorrow morning.
Do we want to ask
I won't be here.
Jen?
You won't be at before 8:45. What time will you be here?
Around 10.
At 10, okay. Well, we'll come in and we'll work on our own a little bit and just go through that will be fine.
And decide if, what if any changes we heard about today we want to make?
Yeah, I mean, it's not so much that we want to make, but that makes sense for us to integrate into the bill some way. That we weren't gonna make the changes that we heard exactly because we're going to hear from AHS and Green Mountain Care Board also. So it's just that these are the points of concern where we could make changes. We might be able to do something right off the bat.
Just for clarity, 8:45 start.
Yeah. Uh-huh. I think I have a meeting at 8:30. And then at 9:30, we have some guests coming in for a short period of time. And then, that were scheduled a long time ago. And then, we'll move right on. Good. So